Hi, I am Dr. Arun Prasad. I'm a senior GI bariatric and robotic surgeon at Indraprastha Apollo Hospitals, New Delhi. Today, we shall be talking about the enhanced recovery after surgery, especially when dealing with robotic and laparoscopic gastric bypass bariatric surgery. So, metabolic and bariatric surgery is a surgery where we manipulate normal organ systems to achieve alteration in physiology, resulting in resolution of the disease process and leading to weight loss. So, there are two main types of surgery which are common in India, and this is an animation that will give you an idea of how these two surgeries are being done. So, first, we see a video clip of a sleeve gastrectomy procedure, and that is the stomach. This is how food passes down. And during a sleeve gastrectomy procedure, what do? We would be using staplers, and we staple this much stomach out, which is about 80% of the stomach, leaving behind 20%. So the fundus, the ghrelin producing area, is removed, leading to better satiety. Also, the food is now going to be passing down rapidly into the bowel, hence reducing the anti-incretins and increasing the GLP-1 levels. The second operation which we will be talking about today is the gastric bypass. Here, with the use of staplers, we have created an upper stomach pouch. Small intestine is divided there, and it's taken up and joined to that stomach pouch. And the end, which is now there after the stapler, is taken and joined to the intestine in an end to side. So now the food passes like that, and the juices will pass down and they will mix up at the bottom. So that is how a gastric bypass surgery is done. So in gastric bypass, what happens? The duodenum gets bypassed, thereby leading to a reduction in the anti-incretins. There is a change in the bile acids, early transit of food to the ileum, leading to an increase in the GLP-1 levels. There is malabsorption of fat especially, and there is an alteration of the gut microflora, which leads to an improvement of the fat and carbohydrate metabolism for the body. There are two types of bypass, the Roux-en-Y bypass, where there are two limbs, and there is the mini gastric bypass, which is a single limb with a longer BP limb, which is preferred for super obese and in various other patients. So these are the two types of bypass. So why is there slow recovery after a gastric bypass operation? There could be medical complications such as bleeding, infection, adverse reactions to anesthesia can extend the hospital stay. Inadequate pain control or patients experiencing significant postoperative pain may require additional monitoring before discharge. There could be difficulty in mobilizations. Patients who struggle to walk or move around post-surgery may need more time in the hospital to ensure that they can safely do so. Some patients experience nausea or vomiting after bariatric surgery, which can delay their ability to tolerate oral intake. There could be inadequate recovery. So that is, if patients don't recover as expected or have impaired respiratory function or oxygen saturation, they may need to stay longer for observation. Mental and emotional well-being is important. Patients with psychological concerns or emotional distress may be kept longer for psychiatric evaluation and support. Nutritional concerns could be there, that patients can tolerate liquids and are not at risk for dehydration is crucial before discharge. Social support, patients who do not have a responsible adult to accompany them home or care for them post-discharge may be kept longer until a suitable support system is arranged. There could be delayed ambulation, whereby difficulty in walking and the absence of physical activity after surgery can delay recovery and consequently discharge. So what is ERAS? In 1990s, the concept of ERAS began to take shape when several surgeons and anesthesiologists started experimenting with strategies to improve the surgical experience for patients. Researchers showed that various elements of care, including early oral intake, minimally invasive surgery, and post-operative patient education, could significantly reduce complications and hospital stays. ERAS protocols highlighted the importance of collaboration among multiple medical specialties, including surgeons, anesthetists, nurses, dietitians, and physiotherapists. So in the 2000s, surgeons, hospitals, and societies worldwide started recognizing the potential for improved patient outcomes, and guidelines were developed in late 2000s for adoption of ERAS. So the global impact after 2010, it has continued to evolve, and many specialties, including bariatric specialty, is using this. So coming finally to what is the ERAS protocol, how do we use it in bariatric surgery? So firstly, pre-operative patient education is very crucial, whereby we provide patients with comprehensive information about the surgery, expectations, and post-operative care to reduce anxiety and ensure better compliance. In other words, it's very important for people to know what is going to be happening during and after surgery, and their cooperation is very crucial. Assess the patient's nutritional status pre-operatively and optimize it with dietary counseling, protein supplementation, and vitamins. This also helps in early recovery. Carbohydrate loading is a concept whereby the patient is encouraged to consume carbohydrate-rich drink before surgery, and this enhances the energy levels and reduces the insulin resistance. Pre-operative fasting. Minimize fasting duration before surgery, allowing patients to consume clear liquids up to 2 hours before surgery. Short-acting anesthetics. The use of short-acting anesthetic to reduce post-operative grogginess and facilitate early ambulation is very important. We should minimize the use of nasogastric tube, avoid the routine use of NG tube, which can cause discomfort and be unnecessary in many cases. I don't see any role of putting a nasogastric tube after a gastric bypass surgery. We don't use it at all. Post-operative pain management is very important. Again, multimodal analgesia to control pain and reduce the need for opioid medications, which can slow down recovery. So avoid opioids, give NSAIDs, perfalgan, diclofenac. These are the combinations being used. Early mobilization. Encourage patients to start moving as soon as possible after surgery to prevent complications like DVT and expedite the recovery. We make our patients walk to the toilet 4 hours after surgery. Early oral intake with a clear fluid diet soon after surgery, advancing to a full liquid diet and then solid foods as tolerated. Minimize urinary catheter use, avoid unnecessary catheterization to reduce the risk of urinary tract infection. In my bariatric patients, where the surgery and gastric bypass usually takes around 1 hour, there is absolutely no need for any urinary catheter. Patient is asked to go and pass urine before anesthesia, and that should be it. Routine prophylactic antibiotics are administered before surgery, and you can discontinue them 24 hours after surgery. Thromboembolic prophylaxis, whereby we impress the compression stockings and early ambulation to prevent blood clots. No nasogastric decompression, as I've already mentioned. Early removal of drains and tubes. Remove the surgical drains and tube as soon as possible so that it minimizes the discomfort and encourages mobility. The enhanced recovery pathway is crucial. Implement a structured care pathway that outlines the patient's journey from pre-admission to discharge, including specific milestones and discharge criteria. Involve patients in their care decisions, including managing their pain and mobilizing early. Reduce opioid use, minimize the use of opioids for pain, and consider non-opioid alternatives, as I had suggested earlier. Facilitate communication between the surgical team, nursing staff, and the patient to ensure a smooth transition from surgery to discharge. We have laparoscopic surgery, which is widely available, cheaper, but it uses non-articulating instruments and assistant dependent, while robotic bariatrics gives us a true 3D articulating 4-control pay surgery, good for super obese and revision. It is expensive, however, it causes less pain because the instruments move around at the fulcrum and cause minimal tissue trauma, thereby less pain and early mobilization after surgery. So I will show you a small clip on how we do the robotic bariatric surgery. So that's a patient around 275 kg. This is the robot which is being brought to the head end of the patient. And this process is known as docking, whereby we connected the instruments to the robot. The intestine is been made, as you saw the pouch in the cartoon, the animation earlier. That's the stomach pouch. The intestine is now being stitched from the side to the stomach. Patient in recovery, shifted to the room 1 hour later, and here you can see 6 hours after surgery, he is walking to the toilet. Patient did well, and we've got some pictures of his. That's him before the surgery. 6 months after surgery, he's still wearing the same jeans. 1 year after surgery, he's bought a new pair of jeans. So we've got many patients who've had good, successful bariatric surgery, and with the use of ERAS protocol, we are usually able to discharge most of our patients 24 hours after surgery. These are few of the other examples which you can see. We've been doing the robotic surgery since 2013, and I've done the first world's robotic anastomosis gastric bypass. This was almost 10 years ago. We have demonstrated our surgery at international forum and spread the word of how bariatric surgery, ERAS, and robotic surgery can be combined for quick recovery and better outcomes in patients. Anyone wants to contact me, you just need to Google. Me and my team are here. With that, I come to the end of my presentation. Thank you very much for listening. If there are any questions, I'm happy to answer them now.